Will senior care in Canada one day break the bank? Probably not, contrary to common perceptions. Four health policy experts, Dr. Robyn Tamblyn, Dr. Ivy Bourgeault, Dr. Neena Chappell, and Dr. Michel Grignon, explain why money is not the biggest issue when talking about senior care in Canada. It's rather about adapting the resources and services that are already available. Dr. Bourgeault believes there is too much fear-mongering regarding the ever-growing senior population.
I do not agree with analogies equating the aging demographic to a tsunami. It is not a tsunami. It is a slow-moving demographic shift. It changes 1 year at a time. So we have time to prepare, but we need to get started.
She believes Canada should be taking this issue on as a structural problem, not simply a financial one. The healthcare system, as created in the 1950s, is no longer representative of the current demographics.
The way that we have structured care, and it has become ingrained in policies and programs and funding and regulatory arrangements, reflects population health needs and a demographic that no longer exists, focused around acute care and around a largely young population.
And not all baby boomers who hit the age of 65 will immediately require extensive care and put pressure on the system, adds Dr. Chappell.
And we know that the most extensive use of what we think of as health services, so of hospitals and doctors, those types of services, comes closer to death. So it's within 6 months, sometimes within a year of dying.
In fact, healthcare in Canada is not costing more because there are more seniors, says Dr. Grignon. Rather, it's because we are using newer and more expensive drugs and technologies.
It is going to contribute to an increase in spending, but it's not going to be the major driver of healthcare spending. Or to put it differently, if aging of the population was the only reason for an increase in healthcare spending, I think everybody would be happy. The crucial question is, do we benefit more from these new technologies than what we pay, than the cost, or do we benefit less?
Nonetheless, Dr. Bourgeault says the government should take certain steps to better prepare for the shift in demographics.
I think, first of all, what we would need is a better appreciation of what the present and future population health needs are going to look like. Second, put in place a system of living, housing, and care structures in place that best meet those needs flexibly. And third, is an appreciation of what types of capital one would need to invest in that capital in terms of shifting structural costs from hospitals and long-term care to home, what that's going to look like, and most importantly, an explicit appreciation of what human resources we are going to need in order to make that happen. In order to appreciate what we need in order to make that happen, we need to know what do we have and what do we need and how do we get from A to B. How do we get from what we have to what we need? But if we don't know what we have, we make projections about what we need, we're going to be making policy decisions, with a blindfold on. It's not the way to go forward.
But does Canada have enough money to ensure all senior Canadians get proper care in the future? Yes, believe the experts, but inefficiency has to be reined in, advises Dr. Tamblyn.
The verdict for most people is you're spending $220 billion on healthcare for 33 million people. We have enough money in the system.
Dr. Grignon suggests a few areas where money can be saved.
But we need to keep in mind that the true reason why we spend more is because we still die in hospitals. 60% of deaths in Canada take place in hospitals, and one night in a hospital costs a lot of money. If we really want to bend the cost curve, that's where we should look.
Another way to avoid going over budget is to reduce the costs of drugs and rein in overprescriptions by doctors, explains Dr. Tamblyn.
And we could do a much better job probably getting the price down if we did some sort of bulk purchasing as a nation. The second issue is the issue of prescribing. And I think there you've got overuse, underuse, and misuse. You've got all three of them happening simultaneously.
Human resources are also an extremely important part of healthcare costs. Better managing resources and the healthcare workforce are necessary, believes Dr. Bourgeault.
Healthcare is by nature labor intensive. And so if you develop a policy or strategy or reform without explicitly appreciating what the human resources implications of that strategy are, your strategy is ultimately going to fail. because you're making decisions completely blind to the main input into the strategy. So without there being a strategy to understand who is out there right now, what are they doing and where are they working and how, without that appreciation, if we don't know what our baseline is, we have no means of trying to plan around future needs.
That is why she believes more data is needed about caregivers and healthcare workers across the country.
We have no idea how many personal support workers there are out there. It's an unregulated sector, but at the very least, we should have some type of understanding of how many there are and what are the common standards of education and competency and tasks that they can undertake.
Many healthcare workers are not being used for the tasks they were trained for.
On the one hand, we have a waste of human resources, a waste of competencies and skills that are not being utilized in the system. And at the other end, we have the inappropriate transfer of tasks to largely family members who do not have the competency, skills, and confidence. So there really isn't a rational approach to the application of the health workforce.
Dr. Chappell says politicians will have to reallocate money to better reflect population needs.
Well, they have to at least reshape, restructure, reorganize. They have to integrate home care within a system where the money is flexible so that people can be kept at home, want to stay at home, receive home care, for example, which is less expensive than putting them into an institution.
And finally, Dr. Grignon is a proponent of a publicly funded long-term care plan.
The main reason why I suggest a universal public plan for long-term care, well, it has to do with, let's say, the efficiency of financing. So I think it's almost impossible to support or to finance long-term care through private insurance market. Private insurers, they don't really have what it takes to cover that kind of risk. Saving to pay for long-term care, I don't think that makes much sense because we have to keep in mind that approximately 20% of us are going to need some kind of a really high-cost long-term care. So if you save, but you have 80% chances of never using that money, it's lost. So if we want it to be affordable, what we need to have is an adult discussion. So we need to agree that we are going to spend more. It makes sense to spend more on healthcare in the future. How do we want to spend that money? Or how do we want to finance that increased spending? Do we want to go the U.S. way, where people do that privately and pay higher premiums, or do we want to do it the Canadian way and go public?
Such a plan is not rocket science, he adds. The government simply has to fund it adequately. Ultimately, Dr. Tamblyn, Dr. Bourgeault, and Dr. Grignon believe that to ensure the viability of senior care, one last piece of the puzzle is needed, and that is political will. For Evidence Network, I'm Melanie Holoboski.